Welcome to the Hospital Medicine Unplugged podcast. Today, we are undertaking a critical deep dive into a patient population that requires, well, the utmost acuity, decisiveness, and rapid evidence-based management. Patients presenting with oncologic emergencies.
This really is high-stakes medicine. Our focus today is to dissect and solidify the principles for acute hospitalist management of these potentially life-threatening conditions.
Right.
We're discussing situations that result directly from advanced cancer or, increasingly from the aggressive treatments we use to combat it.
And the sheer volume is significant.
It really is. These emergencies drive millions of emergency department visits annually, demanding complex inpatient stays, often complicated by rapid decompensation and profound comorbidities.
And the challenge really lies in that tight clinical timeline. Delaying diagnosis or intervention, even by a few hours, can unfortunately lead to devastating, often irreversible sequelae.
Things like permanent neurologic deficits or catastrophic organ failure. That speed requirement demands a structured approach. So we'll examine these emergencies through four primary actionable categories: metabolic disturbances, hematologic crises, structural compressions, and finally, the increasingly complex world of treatment-related and infectious toxicities.
Okay.
For any patient entering your hospital with a known malignancy or maybe high-risk features, that high index of suspicion has to immediately activate the appropriate protocol.
Let's unpack those core principles of acute management then. Unlike some general medicine cases where you might have a bit of a margin for observation, the oncologic emergency demands immediate identification and triage.
Yeah, and the presentation can be notoriously nonspecific.
Right, a complaint of maybe increased fatigue, some mild confusion, or minor shortness of breath.
Exactly. But the hospitalist has to maintain the vigilance to trigger a rapid, focused workup.
So the foundational approach always begins with standard advanced life support protocols.
Always. Immediate priorities remain the stabilization of airway, breathing, and circulation, the ABCs. This means supplemental oxygen and robust hemodynamic support, which often translates to aggressive intravenous fluids. However, if that fluid resuscitation fails, timely initiation of vasopressors is necessary to manage distributive shock.
Which can be triggered by sepsis or even things like cytokine release syndrome.
Precisely. The difference here, compared to general internal medicine, is the need to simultaneously layer in targeted interventions that are specific to the presumed oncologic pathology.
That layering is crucial. Can you detail the philosophy behind those immediate targeted interventions? The ones the hospitalist has to initiate based on suspicion, often before the definitive diagnosis or consultation is complete.
Certainly. These are interventions that must be time-critical to prevent functional loss. So if your assessment suggests malignant spinal cord compression, immediate high-dose corticosteroids like dexamethasone simply cannot wait.
Okay.
If your bedside point-of-care ultrasound, your POCUS, reveals features highly suggestive of cardiac tamponade, urgent pericardiocentesis under echo guidance is the immediate life-saving step.
Yeah.
We're talking about interventions that the hospitalist must be prepared to enact within minutes, not hours, relying on clinical acumen and available technology while simultaneously getting those subspecialty services notified.
And this speaks directly to the necessity of multidisciplinary collaboration. We initiate the rapid stabilization and targeted intervention, but the definitive long-term management relies on a complex network: oncology, critical care, often specialists in radiation or surgical neurosurgery.
Absolutely. Early notification of oncology is non-negotiable because the definitive therapy is almost always disease-specific.
Makes sense.
Whether the patient needs emergency radiation for compression, rapid initiation of specific chemotherapy, or maybe endovascular stenting for superior vena cava syndrome, the oncologist needs to be involved from the moment the patient hits the door.
Okay.
And crucially, that coordination facilitates the appropriate triage, sometimes requiring an intensive care unit level of monitoring to safely manage, say, emergency chemotherapy protocols or the complex hemodynamic instability seen in cytokine release syndrome.
Beyond the immediate life-saving procedures, the hospitalist carries, I think, the unique burden of aggressive symptom control and, equally important, the early initiation of goals of care discussions. This patient population is inherently vulnerable.
That's a critical point. Aggressive symptom management is a foundational principle of palliative care that should run concurrently with acute intervention. This includes appropriate titration of opioids,
Which are first line not just for severe cancer pain, but often for dyspnea too, right? Related to effusions or pulmonary involvement.
Exactly. And managing nausea, vomiting, and severe anxiety must also be addressed proactively. Given the acuity and often, frankly, the poor prognosis associated with many of these emergencies, early involvement of palliative care is paramount.
It really helps facilitate those essential goals of care discussions.
It does. For patients with advanced disease, palliative care specialists help align aggressive interventions with the patient's long-term wishes, ensuring we coordinate transitions to hospice care when appropriate and preventing, futile interventions.
Okay, let's shift into the specific categories now, beginning with metabolic emergencies. These often involve rapidly escalating electrolyte chaos. We can start with tumor lysis syndrome, or TLS, which requires highly protocol-driven management.
TLS is a true medical catastrophe. It results from the massive rapid release of intracellular contents, potassium, phosphate, nucleic acids, into the circulation.
And it's most commonly triggered following cytotoxic therapy in those highly proliferative tumors.
That's right. Things like Burkitt lymphoma or high-grade acute leukemias are the classic culprits.
And the diagnosis relies on the acute recognition of that classic laboratory tetrad.
Exactly. We look for hyperuricemia, hyperphosphatemia, hyperkalemia, and the resultant hypocalcemia.
Which is driven by the calcium binding to the excess phosphate.
Correct. This combination can lead to life-threatening acute kidney injury due to urate and calcium phosphate precipitation in the renal tubules, alongside severe cardiac arrhythmias from the hyperkalemia.
So our management protocol hinges on two major pillars: aggressive hydration and uric acid reduction. Let's delve into the nuances of the hydration strategy. Is normal saline the universally accepted standard here?
Well, the standard remains vigorous intravenous hydration, aiming for a high urine output, typically 2 to 3 liters per square meter per day. The key goal is high volume flow to flush the precipitate.
Okay.
While normal saline is often used, some institutions might prefer adding sodium bicarbonate to alkalinize the urine, though this practice is controversial.
Right. It can worsen calcium phosphate precipitation if the patient isn't already alkalotic.
Exactly. So it's generally not recommended in those cases. The critical takeaway is high volume input to maintain urine output greater than 100 milliliters per hour while avoiding overdiuresis with loop diuretics, unless, of course, the patient develops volume overload after adequate repletion.
And regarding uric acid reduction, what differentiates the use of allopurinol versus Rasburicase, particularly for the hospitalist facing established TLS?
That's a key distinction. Allopurinol works by inhibiting xanthine oxidase, so it prevents the formation of new uric acid. It's excellent for prophylaxis in high-risk patients before chemotherapy begins.
Okay.
However, if you're faced with established TLS where uric acid levels are already sky-high, Rasburicase is the preferred agent.
Because it breaks down existing uric acid.
Correct. Rasburicase is a recombinant urate oxidase enzyme that rapidly converts existing uric acid into the highly soluble allantoin. Its effect is quick, often reducing uric acid levels by 80% within 4 hours.
Wow.
Which makes it the necessary rescue drug, despite its high cost. And importantly, the potential for inducing hemolytic anemia in patients with G6PD deficiency. That's a crucial screen.
Good point. What about managing the resulting electrolyte chaos, specifically the hyperkalemia?
The hyperkalemia can be immediately life-threatening and requires standard stabilization protocols. Calcium gluconate for cardiac membrane stabilization, insulin dextrose, maybe binding resins.
But the underlying driver is still the cell lysis.
Exactly. Unlike general medical hyperkalemia, unless you address the lysis or eliminate the excess potassium via renal replacement therapy, or RRT, it will recur rapidly.
So RRT is indicated for refractory hyperkalemia.
Yes, or severe refractory metabolic acidosis, or severe acute kidney injury resulting from the syndrome itself.
Okay. Next, let's discuss hypercalcemia of malignancy, or HCM, the other major electrolyte threat.
HCM is extremely prevalent. We see it associated not only with solid tumors like breast, lung, and renal cancer, but also highly prevalent in multiple myeloma.
And the symptoms are notoriously nonspecific again.
Very much so, ranging from neurocognitive changes, profound weakness, polyuria leading to volume depletion, and severe gastrointestinal issues like nausea and constipation. Our management is a carefully tiered approach.
What is the mandatory first-line intervention for HCM, regardless of the cause?
Step 1 is always vigorous intravenous saline hydration. The overwhelming majority of these patients are volume depleted due to that calcium-induced nephrogenic diabetes insipidus.
Right, the kidneys can't concentrate urine properly.
Correct. So we must restore euvolemia and promote calcium excretion. This typically starts with a rapid 1 to 2 liter bolus of 0.9% saline, followed by an infusion rate of maybe 200 to 500 milliliters per hour.
With close monitoring, of course.
Absolutely. We have to monitor volume status closely, especially in patients with baseline heart failure.
Once euvolemia is established, the next therapeutic step targets the bone.
Right. Step 2 involves inhibition of bone resorption, typically achieved using intravenous bisphosphonates. Zoledronic acid, 4 milligrams intravenously, or pamidronate, 60 to 90 milligrams intravenously, are the workhorses here.
But there's a delay with these, right?
There is. That's the crucial caveat. These agents have a lag time. Their calcium-lowering effect isn't maximal until 48 to 72 hours later, so they can't be relied upon for immediate symptom relief.
And we need to watch renal function?
Definitely.
Oh.
We must carefully dose adjust or even avoid bisphosphonates in the context of significant underlying renal impairment.
So if the patient presents with severe symptomatic hypercalcemia, say altered mental status, what's the bridge therapy we use while waiting for the bisphosphonates to kick in?
That's step 3, calcitonin. It works by reducing osteoclast activity and increasing renal calcium excretion. It provides a rapid, often measurable calcium reduction within 4 to 6 hours.
Making it the perfect bridge therapy.
Exactly. However, its effect is transient, usually lasting only about 48 hours, and tachyphylaxis, where it stops working, develops quickly. The dose is typically 4 to 8 international units per kilogram every 8 to 12 hours.
What about refractory cases, especially those with renal compromise? Denosumab seems to be used more often now.
It is. Denosumab, a rank ligand inhibitor, is highly effective and, importantly, doesn't require renal dose adjustment, making it invaluable for patients with renal failure.
But there are risks.
Yes, we must be careful. Its effect is very potent and long-lasting, increasing the risk of severe refractory hypocalcemia weeks after administration. This requires very proactive calcium and vitamin D supplementation and monitoring. And I'd add, for steroid-responsive malignancies like lymphoma or myeloma, glucocorticoids can play an adjunctive role in lowering calcium. Finally, dialysis is reserved for those who are unresponsive to medical therapy and are in frank renal failure.
Our final metabolic emergency is the syndrome of inappropriate antidiuretic hormone secretion, or SIADH. While often less immediately dramatic than TLS or HCM, it carries severe neurological risks if mistreated.
Right. SIADH is most often linked to small cell lung cancer, which can produce ectopic antidiuretic hormone, ADH. This presents as euvolemic hyponatremia due to inappropriate water retention.
And the management is driven by symptoms and severity.
Entirely. The management depends on the patient's symptoms and the severity of the hyponatremia.
What is the greatest risk in treating severe hyponatremia in this population?
The risk of osmotic demyelination syndrome, or ODS, from overly rapid correction is our primary concern. That's the nightmare scenario.
So for mild asymptomatic cases?
Fluid restriction is the cornerstone, allowing gradual self-correction. However, for severe or symptomatic hyponatremia, especially if the patient is seizing or showing profound altered mental status, hypertonic saline must be administered promptly.
But cautiously.
Very cautiously. We must target a correction rate of no more than 8 millimoles per liter increase over any 24-hour period, and certainly stopping the hypertonic saline when symptoms resolve. The ultimate long-term solution, of course, requires treating the underlying small cell lung cancer.
Okay, transitioning to hematologic emergencies. These conditions require immediate volume or cellular reduction to prevent microvascular occlusion, starting with hyperviscosity syndrome.
Hyperviscosity syndrome results from either pathologically elevated serum proteins, think Waldenstrom macroglobulinemia, or multiple myeloma, or extreme cellular burden, like in certain acute leukemias. The symptoms arise because the high viscosity impairs microcirculation.
What are the specific clinical features that demand emergent action, that classic triad?
Yes, we look for the triad. Mucosal bleeding, which can often be subtle. Visual disturbances due to retinal vessel engorgement, and neurologic deficits ranging from headache to frank stroke.
And the acute management is highly mechanical.
It is. Emergent plasmapheresis. This procedure physically removes the abnormal serum proteins to rapidly reduce the viscosity and provide immediate symptom stabilization. But that's just stabilizing. It must then be followed by disease-directed chemotherapy to address the underlying plasma cell or lymphoproliferative disorder.
Closely related and arguably more immediately dangerous in certain leukemias is leukostasis.
Right. Leukostasis is seen predominantly in acute leukemias, especially AML, when the white blood cell count typically exceeds 100,000 per microliter. The sheer mass of poorly deformable blasts causes sludge and microvascular obstruction.
Leading to hypoxia and ischemia.
Exactly, particularly in critical areas like the lungs, causing respiratory distress, and the central nervous system, causing altered mental status and stroke. It's incredibly dangerous.
Therefore, the immediate action here is rapid cytoreduction.
Absolutely. Time is of the essence to prevent catastrophic lung or CNS injury. Rapid cytoreduction involves starting high-dose hydroxyurea immediately to suppress cell proliferation.
And leukapheresis?
Leukapheresis can also provide immediate physical removal of the blasts, though it's often used in conjunction with, not instead of, chemotherapy. Urgently initiating definitive chemotherapy is required, but often we have to perform this initial rapid kill phase under ICU monitoring because of the extreme risk of precipitating severe tumor lysis syndrome.
That makes sense. You're lysing a huge number of cells.
A massive tumor burden.
Our final hematologic emergency is disseminated intravascular coagulation, or DIC. This complex consumptive coagulopathy is often a harbinger of a highly aggressive underlying malignancy.
DIC is characterized by widespread unregulated activation of the clotting cascade, which paradoxically results in both microthrombi formation and widespread bleeding.
Why bleed?
Due to the consumption of platelets and clotting factors. It's frequently seen with severe sepsis, but in oncology, it's a signature of acute promyelocytic leukemia, or APL, which releases potent procoagulants.
What are the key laboratory findings hospitalists should use to confirm the suspicion? We're looking for evidence of consumption.
Exactly. Laboratory findings show consumption. An elevated D-dimer reflecting ongoing fibrinolysis, a low fibrinogen level, and thrombocytopenia. The peripheral blood smear might show schistocytes.
Those fragmented red cells.
Right, reflecting red cell fragmentation as they pass over the microthrombi. Management is primarily supportive transfusion of platelets and coagulation factors like cryoprecipitate to maintain hemostasis. But the definitive therapeutic maneuver is prompt treatment of the underlying malignancy.
Like ATRA for APL.
Exactly. In APL, for instance, immediate initiation of all-trans-retinoic acid, or ATRA, dramatically halts the release of those procoagulants. I'd also mention that recombinant human-soluble thrombomodulin is used in some international guidelines for sepsis-related or certain types of DIC, though perhaps less common in purely malignancy-driven DIC outside of APL.
Okay, moving to structural emergencies. These involve mass effect requiring urgent mechanical relief to preserve function. The most time-sensitive in terms of neurologic outcome is malignant spinal cord compression, or MSCC.
MSCC is defined by compression of the spinal cord or cauda equina by epidural tumor. Often it's metastatic disease from prostate, breast, or lung cancer.
And the diagnostic imperative is urgent MRI.
Urgent MRI of the entire spine. That's critical, not just a single symptomatic area, to fully delineate the extent of disease and identify any skip lesions before irreversible paralysis sets in.
What's the initial immediate therapeutic intervention for MSCC, the one initiated on clinical suspicion even before the MRI result?
It's the immediate administration of high-dose corticosteroids. Dexamethasone is the agent of choice because of its minimal mineralocorticoid effects and potent anti-inflammatory properties.
And the dose.
We initiate with a 10 to 24 milligram intravenous bolus, followed by 4 to 6 milligrams intravenously every 6 hours. The goal is specifically targeting the reduction of local vasogenic edema surrounding the spinal cord and stabilizing neurologic function pending definitive treatment.
How does the hospitalist and the multidisciplinary team decide between definitive treatment routes, emergency surgery, versus radiation therapy?
It's a complex decision. It relies heavily on the patient's performance status, the radiosensitivity of the tumor, and the degree of bony instability. We often use scoring systems like the Spinal Instability Neoplastic Score, or SINS score, to help guide the decision.
So when is surgery preferred?
Surgical decompression is generally preferred for patients with good performance status, a limited number of metastatic sites, rapidly progressive symptoms despite steroids, or inherent spinal instability identified on imaging or by the SINS score.
And radiation?
Radiation therapy remains the mainstay for widespread disease, or for tumor types that are highly radiosensitive like myeloma or lymphoma, and of course for patients who are not surgical candidates. Crucially, regardless of the definitive therapy, early rehabilitation must be initiated to maximize any potential functional recovery.
Good point. Next, let's address superior vena cava syndrome, or SVC syndrome.
SVC syndrome results from external compression or internal occlusion of the superior vena cava, most commonly by mediastinal malignancies like lung cancer or non-Hodgkin lymphoma.
And it presents with those characteristic symptoms.
Right. Facial swelling, dyspnea, plethora, and visible venous distension in the neck and chest wall, sometimes called the Cate distribution.
What are the immediate supportive measures a hospitalist must implement while waiting for the diagnosis and definitive plan?
Initial steps include head elevation and supplemental oxygen. But while we stabilize the patient, the critical issue is balancing the need for rapid decompression versus the need for a definitive tissue diagnosis.
That's a key tension.
It is. According to guidelines, unless there is imminent airway compromise or significant cerebral edema, suggesting severely raised intracranial pressure, we should strive for a definitive tissue diagnosis by biopsy or cytology before initiating definitive therapy.
Why is that so important?
Because the histology dramatically dictates the subsequent management.
Okay, so how does the histology dictate the treatment plan?
Well, for small cell lung cancer or high-grade lymphoma, which are highly chemosensitive, chemotherapy is generally the preferred first-line treatment. It often leads to rapid tumor shrinkage and decompression.
And for non-small cell?
For non-small cell lung cancer, which is typically less sensitive to initial chemotherapy, radiation therapy and oligo-anuric stenting are the mainstays. Vascular stenting is a crucial interventional tool because it provides rapid symptom relief, often within 24 hours.
So it's indicated for refractory cases or very acute, severe presentations.
Exactly, especially when immediate decompression is necessary due to cerebral symptoms or severe respiratory distress. Glucocorticoids are sometimes considered as an adjunct, especially if a highly steroid-responsive tumor like lymphoma is suspected. But tissue diagnosis remains key if possible.
Our final structural emergency is malignant pericardial effusion leading to cardiac tamponade.
This is a purely hemodynamic, life-threatening emergency. Malignant effusions are commonly seen in metastatic breast cancer, lung cancer, melanoma, among others.
And the physiology is restricted filling.
Precisely. The buildup of fluid restricts diastolic filling, leading to hypotension, tachycardia, and that classic finding of pulsus paradoxus. If there is hemodynamic compromise, Beck's triad, pulsus, hypotension, the immediate intervention is urgent pericardiocentesis.
Done under echo guidance.
Preferably, yes. Urgent pericardiocentesis performed under echocardiographic guidance provides immediate, dramatic, life-saving hemodynamic relief by reducing the intrapericardial pressure.
But recurrence of the effusion is a significant clinical problem in these patients, isn't it?
It is a major problem, especially since the underlying malignancy is often refractory. For recurrent effusions, simple repeat centesis is often insufficient long-term.
So what are the strategies for prevention?
We need to consider strategies like prolonged indwelling catheter drainage, sometimes followed by sclerosing agents, or the placement of a surgical pericardial window, which allows continuous drainage into the pleural or peritoneal cavity.
And sometimes instilling chemo directly.
In selected patients, yes. Intrapericardial instillation of cytostatic agents, such as bleomycin or cisplatin, can reduce recurrence rates. But it's paramount that any aggressive management here aligns perfectly with the patient's overall prognosis and stated goals of care. This requires careful consultation with cardiology, oncology, and often palliative care.
Okay, let's shift focus now to complications arising from modern cancer therapy itself. The most frequent and immediate concern for any hospitalist covering oncology is probably febrile neutropenia.
Absolutely. Febrile neutropenia requires immediate action. The definition is clear. Fever, an oral temperature greater than 38.3 degrees Celsius, or a sustained temperature greater than 38.0 degrees Celsius for 1 hour in a patient with an absolute neutrophil count less than 1,000 per microliter, typically following cytotoxic chemotherapy, sometimes defined as less than 500 depending on the source.
And this is a time-sensitive protocol often referred to as the golden hour.
Absolutely. The mortality risk increases exponentially with every hour of delay in starting antibiotics. Immediate empiric broad-spectrum antibiotics must be initiated within 1 hour of presentation.
After cultures, of course.
Yes, after a thorough clinical evaluation and obtaining blood cultures from all lines and peripheral sites. The standard approach is monotherapy with an anti-pseudomonal beta-lactam.
What are the standard monotherapy options, and are there specific indications for choosing one over the other?
The primary options are cefepime, piperacillin-tazobactam, or a carbapenem like imipenem or meropenem. Cefepime is a common and excellent choice, offering broad gram-negative and anti-pseudomonal coverage.
And piptazo.
Piperacillin-tazobactam provides excellent broad coverage, including gram-negative, anti-pseudomonal, and anaerobic coverage, which is useful if an anorectal, perianal, or intra-abdominal source is suspected. Carbapenems are typically reserved for patients who are hemodynamically unstable or have known colonization or high suspicion for extended-spectrum beta-lactamase (ESBL)-producing organisms.
How do hospitalists appropriately risk stratify these patients to guide inpatient versus potential outpatient management using the MASCC score?
Exactly. We use established risk stratification tools, specifically the Multinational Association for Supportive Care in Cancer, or MASCC score. This score helps identify low-risk patients, those with a high score who might be candidates for oral antibiotics and close outpatient follow-up.
And high-risk patients.
High-risk patients, defined by the MASCC score being low, less than 21 usually, significant comorbidities or hemodynamic instability, absolutely require hospitalization and intravenous antibiotics. Components of the MASCC score include things like burden of illness, presence of hypotension, presence of COPD, and outpatient status at fever onset.
When must we escalate therapy beyond the initial monotherapy? Specifically, when should we add vancomycin?
That's a common question. Vancomycin or other additional agents targeting resistant gram-positives are reserved for specific clinical high-risk situations. We add vancomycin if there's clinical deterioration despite initial therapy, suspected catheter-related infection, pneumonia identified on imaging, severe mucosal damage like mucositis, or if we suspect methicillin-resistant staph or ES colonization or infection based on history or local epidemiology.
And antifungals.
Empiric antifungal therapy is indicated if the fever persists beyond 4 to 7 days despite adequate broad-spectrum antibiotics. This raises suspicion for an invasive fungi infection, like Candida or Aspergillus. The common empiric choices include lipid formulations of amphotericin B or broad-spectrum azoles like voriconazole.
Okay. Let's move to the emerging toxicities associated with modern immunotherapy, specifically immune checkpoint inhibitor toxicities, or IRAEs. These seem increasingly common.
They are, and the challenge with IRAEs is their protein systemic nature. They are immune-mediated reactions that can affect virtually any organ system, often weeks or even months after treatment initiation.
So common manifestations are things like colitis,
pneumonitis, myocarditis, hepatitis, a whole range of endocrinopathies like thyroiditis or hypophysitis. The symptoms can start insidiously but can progress rapidly to life-threatening grade 3 or grade 4 emergencies.
Given that they are immune-mediated, what is the core management strategy? Is it always immunosuppression?
Generally, yes. The core strategy across most affected organ systems is immunosuppression, typically starting with high-dose corticosteroids. For grade 3 or grade 4 toxicities, which involve severe symptoms, inability to perform activities of daily living, or threat to life, high-dose methylprednisolone, often 1 to 2 milligrams per kilogram per day intravenously, is required.
And management is organ-specific.
Highly organ-specific and requires immediate multidisciplinary consultation, usually with oncology and the relevant subspecialist. For example, IRE myocarditis requires extremely close cardiac monitoring, often serial troponins and ECGs, and aggressive rapid steroid initiation. Sometimes it even requires additional agents like infliximab or abatacept if refractory.
And for colitis?
For IRAE colitis, if high-dose steroids fail to improve symptoms within about 48 to 72 hours, additional immunosuppressive agents like infliximab or vedolizumab are typically necessary. Prompt endoscopy is also often needed for diagnosis and grading.
Finally, we should address targeted therapy toxicities, particularly cytokine release syndrome, or CRS, which is commonly seen following CAR T-cell therapy, but also with some other agents.
Right. CRS is essentially a massive systemic inflammatory response driven by activated immune cells releasing cytokines. It leads to a state resembling severe systemic inflammatory response syndrome, or SIRS, or even sepsis, with high fever, hypotension, tachycardia, hypoxia, and potential multi-organ dysfunction.
And the management is strictly protocol-driven.
Very much so. It involves a severity grading system, usually based on fever, hypotension, and hypoxia.
What are the key therapeutic agents in managing moderate to severe CRS?
Management relies heavily on supportive care, especially for grade 1 and maybe mild grade 2 CRS. For moderate to severe CRS, grade 2 needing vasopressors, or grade 34, we rely on corticosteroids, but also specific anti-cytokine agents.
Like tocilizumab?
Exactly. Tocilizumab, an anti-IL-6 receptor antibody, is often the first-line specific agent, effectively blocking the downstream inflammatory cascade driven by interleukin-6, which is a key mediator.
And it works quickly.
Often quite rapidly for the CRS symptoms. It's crucial to understand that tocilizumab addresses the cytokine storm, but does not eliminate the CAR T cells themselves. Because these presentations can be explosive, and sometimes involve rapid onset of neurotoxicity, known as ICANS, ICU-level monitoring and strict adherence to institutional protocols are absolutely essential for severe CRS management.
Okay, we have completed our deep dive into the acute management of these four major categories of oncologic emergencies. To quickly recap the highest yield interventions that demand the hospitalist's immediate attention, remember the time-critical elements. For tumor lysis syndrome, it's Rasburicase and aggressive volume management. For malignant spinal cord compression, high-dose dexamethasone and urgent MRI. For severe hypercalcemia of malignancy, fluids first, then calcitonin as a bridge, and planned use of bisphosphonates or denosumab. And for febrile neutropenia, the time-critical administration of anti-pseudomonal antibiotics like cefepime within that first hour.
That's a great summary. And I think what stands out across all these protocols is that while the acute medical response is focused on life-saving technical stabilization and organ preservation, the oncology patient is unique because we are often intervening in the context of advanced, sometimes incurable disease.
Right. We must constantly navigate that complex intersection between highly aggressive acute care and the need for appropriate palliative intervention and goals of care alignment.
Exactly.
The hospitalist is really uniquely positioned to manage this complexity, initiating both the resuscitation protocols and, hopefully, those crucial human conversations about prognosis and quality of life.
Which leads us to our final provocative thought for you, the listener, to consider as you manage these critical patients. It's this. When confronting a patient with a life-threatening acute oncologic emergency, how do you continually and efficiently integrate a frank assessment of the patient's immediate and long-term prognosis into your care plan?
Ensuring that the aggressive, often toxic therapies you initiate truly align with that vulnerable patient's goals and values,
rather than simply treating the lab values or the imaging findings. This ability to pivot between maximal life-prolonging care when appropriate and empathetic, goal-concordant care, perhaps involving withdrawal or limitation of interventions, is arguably one of the highest measures of clinical excellence in hospital medicine, especially in this population.